diabetic hypertensive who presented to us with an ST segment ACS with a normal LV function. PCI to LAD was done on November 2019. This is the angio showing a long segment diffuse lesion in the proximal LAD, which was stented with a very good result in November of 2019. Right now, our plan is to do LAD CTO plasty. As you can see in this angiography, there is a chronic total occlusion of the proximal RCA with bridging collaterals. And our plan is to do CTO angioplasty with an IVUS guidance. Thank you. We go live now.
Good morning, Dr. Saito.
Good morning. Hi.
Hello. Good morning, Rajni.
Good morning, good morning.
Okay.
Yes, LV. You are in LV.
This one? No.
Dr. Saito, are you planning antigrade or you're planning dual injections?
Before doing this manipulation, we have taken the left coronary angiography, and it shows no restenosis, and still the collateral filling to the distal RCA is not good, and also the septal branch root is too much, tortuous. So that means we cannot take the retrograde approach for this patient through septal branch root. And second, the left coronary angiography is not helpful to identify the distal anatomy of the right coronary artery. So we have removed the left coronary artery catheter. Okay? And I'm now trying to engage the RCA, but it's a little bit difficult. This is 700. Oh, very high. Okay. And wedged.
Oh, we can take a side hole.
Side, do you have side
Yeah.
hole? Okay.
Side hole, 7 French side hole. Well, line up. 26 नहीं ले रहे.
Okay. We made 2 side holes in this catheter by using a needle puncture.
If you lose the wire, I'll squeeze your nuts.
Okay. Very difficult. No. Where?
Show me previous one. Previous picture.
No, we didn't take a picture.
Okay.
Okay. Here. Okay.
Okay,
Okay.
that's fine.
Shall we take a picture?
Okay.
Okay. Which one?
Oh,
Right?
It's out. It's
Out?
No,
Ah,
no, it's
no. Okay.
okay.
So still the guiding catheter seating is not perfect. So I want to place the anchoring balloon to the first branch.
Okay.
Do you have field FC? Field FC?
No.
No, no, no. Ah, yes. Except the region. I don't know. You know, I don't know.
Yeah.
Yes, yes. I want to put the anchoring balloon to the
Dr. Saito,
Gaia
Dr.
first.
Saito,
Yes.
do you hear us?
Hi. Buenos dias.
Do you want to take for better support and plus catheter for this case?
Yes. No, I think in this case, yes, that is one solution. But for this particular case, I will place the anchoring balloon to the first branch.
Okay.
How do you
Balloon
think?
you use?
1.5 millimeter balloon.
1.5 alone.
Field FC? This is field FC? Okay.
You want to talk now?
Just okay.
Balloon line?
Yes.
10.
Yes. Maybe because of the wedging. Yeah. Yes. We made a side hole, but still the side hole is not enough.
Yeah.
No, we made it. Yeah,
Yeah.
by needle.
But
No. 1.5.
yeah, 1.5 by 10.
Is the panel can hear us?
Yeah.
Yeah, we can hear you.
Great. So Dr. Saito, why you don't using two catheter? You have one catheter here or two catheter here?
One catheter, because we removed the left coronary catheter, because that provides no information.
No information.
Yeah.
That means no collateral.
No. And also, there is some septal connection, but that route is too much tortuous. Okay.
Saito, while you're working, do you use the Stingray much for re-entry in Japan? I know. a few years ago
No,
you didn't
okay.
use it.
We never use it.
Never use it.
Okay.
Okay, inflation.
6.
6.
So what you use for ADR?
6.
6.
Yes.
Only wire.
Okay, so
See
look
the
at the pressure.
Yes.
Okay? So much difference. Okay?
How you do that?
Okay.
Just remove it.
Yeah. Okay? Now the guiding is not engaged.
Yes.
Okay.
Because you have anchor balloon there now, right?
Yeah. Okay, so
Dr. Saito, what's your first wire strategy there? And will you go with the...
I want to take the Gaia first. Next first.
On
and microcatheter.
Mauricio, do you use much of the Gaia family of wires in your CTO practice?
Yeah. In this kind of case, yes. But normally I'm starting from XTA. But I can see some calcification.
Dr. Saito,
Yes.
would you start Gaia second instead of Gaia first?
No, normally
You always
I'm,
start Gaia first?
Yeah, I'm starting from Gaia first.
What microcatheter are you planning on using?
Carabel.
Carabel.
Where is Carabel? This one. Okay.
Carol 135, right?
Yeah. Put the wire. Put the wire.
Panel discussion on their CTO techniques in this type of lesion. Anyone would use routinely a blunt dissection, or you'd all go antigrade wire escalation, ADR. What are your thoughts on that from the panel?
ADR is very popular in United States already. We have not so much experience of using ADR in Japan.
Rajiv, we're having a little trouble hearing you.
Retrograde is more popular. Oh, ready?
Can you hear the panel?
Hello? You can hear?
Just check it.
We can hear you.
Okay. Goodbye.
So fortunately, I mean, we're lucky at this meeting to have a world-class, of course, Dr. Saito is very well known for his CTO experience. But we also have, I think, one of the most experienced US CTO practitioners, Aaron Grantham, who will be moderating and showing cases later on. So maybe he and Dr. Saito can fight it out of ADR versus antigrade wire escalation.
Dr. Saito, how often you using retrograde nowadays in Japan?
Maybe if we can see some acceptable retrograde route, we are usually starting from retrograde.
So the first approach of retrograde when you see good collateral.
Yeah.
How about you, Raji?
No, I think we typically favor more of a US approach, which is be ready for everything and choose the best strategy that works in an algorithmic manner. And we've learned that from Aaron Grantham and his papers and experience. We would typically do that, recognizing that there's different ways of doing this.
Yeah, understand. Yeah, I think even though we see a good retrograde collateral in the beginning, I think most of us still try antigrade wide escalation first. Looks like Dr. Saito, that why going to somewhere?
No, this is not a good route.
You think there's a branch, right?
I'm advancing the microcatheter, but cannot do it.
You try the wide go into about 7 o'clock instead to 8 or 9.
Yeah. I think you can make it closer, no?
Closer.
It's too far. Screen is too far.
Okay. Yes.
Just
So it looks like good.
I try to advance the microcatheter further. Okay, could do it. Then try again. Test.
Here you go.
Just crossing.
Looks
No,
very
no.
promising, right?
No, might be a subintimal. Okay, shall we take a picture? Yeah, going to.
Yeah, this is subintimal, right?
Yeah.
So
And,
in this
area-
approach,
area-
once the Y go to subintimal, what's the plan? You want to put extra Y, another Y, or you just using the same Y go?
I want to try the same wire. Okay. This projection is good. Okay, come back and repeat, replay the previous one.
Previous one.
Very unusual. Okay, see ne? And this one.
Areo.
Still in the subintimal space, looks like, right?
I don't know.
Yeah. Looks up. Would you worry the hematoma develop soon, Dr. Saito?
Hematome?
Hematoma, yes.
Okay. Difficult. Okay.
Areo. Eleo.
Test. Yeah, this projection is fine. Yeah, but another projection, it's not good. What I have to do?
It's
Okay,
two channel.
RL.
Areo. Yeah. It's look good.
No, I don't think so. It's maybe outside. Okay.
Hello.
Okay. I will place this wire deeply. Okay. Test.
is good. Deep movement is. It's good. Looks good.
I'm not sure. Okay, take a picture. Sorry. Okay.
It's good.
RL.
Areo.
Yes, maybe.
Good.
Yeah,
It's
yeah.
good. It's good.
Okay, LL.
Hello.
Dr. Saito, does the wire feel free?
Yeah, feel free. Okay. So I try to cross this microcatheter cable through the region.
Dr. Saito, your experience of the caravel in calcified lesions, we've had some reports of the tip coming off.
Fragile,
Right.
yes, yes.
So you don't twist the caravel, you just
Yeah,
push
yeah,
it
yeah.
through.
Yeah, it's very important tips.
I just asked
But-
you before the
Can
case,
cross.
Dr. Saito.
Can
You said
cross.
you can twist a little bit.
Okay, so can I have a regular wire?
Yeah. Which one?
No, regular wire.
I mean,
Run through.
A lot of people still twist a little bit of carnival, but not too much.
Panel comments on
Which is the most
microcatheter twisting?
popular microcatheter in United States? Yeah.
Many different caravel, turnpike, Corsair.
How do you choose?
I think when the lesion is very calcified, I'm nervous with the caravel. I think.
Okay, okay.
Your experience, we want to learn from you.
Mostly I'm using fine cross, so I have not so much experience of using this one. Yeah.
This one?
Yeah. Okay. This is what? Which wire?
Run through wires.
Run through? Okay. Okay.
So what, you change a wire now,
Yes, to soft one. This is run through.
one through, okay. I think the important for the fellow, we love to, once you cross the CTO Y, we love to change into the workhorse Y. Just, we don't like to have some distal Y perforation, I guess, if you are not careful.
This is
So
okay.
I think
Okay.
this is important to change the Y.
This is too tight.
Should I hold it?
No, it's okay. Okay, can you push?
And let's see what kind of technique you use, Dr. Saito, to change the Y. You like using the indicator,
Yeah.
the hydroplan technique?
You could use your anchor balloon as a trapper, I'm guessing, right? You
Push,
could pull the anchor balloon back into the guiding catheter to trap it.
Okay, push. Okay?
Okay.
Very good point. Yeah, we really don't need anchor.
Okay. Okay, so take this balloon, okay, this balloon out, and I want to dilate by using this balloon, okay?
So
Comments from
Different.
the panel on your Antigrade microcatheter. I mean, there's no perfect microcatheter. Do you have any particular comments to make?
So Dr. Saito, you take the balloon out, the anchor balloon out.
Yeah,
Do you trap, do you,
no,
no.
just a moment.
Rajiv, to answer your question, you use usually fine cross or the turnpike. Those are my two choices.
How you choose it, Sammy? Any preference, which one?
Fine cross is for the most cases, and then if I have to torque and advance, I like the turnpike with the serrations on it.
But which case you decide to turn, which this case you decide to push?
the length probably matters the most. It probably there's a complex factor, but length definitely matters the most, I think.
I'm usually using the Turnpike LP
Right.
because it has a nice crossing profile. Alternatively, use the Corsair Pro. Those are my choices. Again, I am not a super sophisticated CTO operator.
In my hospital, we decided cost factor too. I think Corsair is the most expensive
yeah.
microcatheter. So I think this
16.
one we take into big consideration. We're using a lot of Turnpike. I think just a little bit cheaper.
Okay. And the 16.
16.
Okay. 16.
Okay.
Okay.
Take a check.
Very tight.
Oh, sorry.
Okay. Take senior. Yeah. Okay. So
Beautiful.
which imaging we take? Which
Stand.
no imaging
IVUS. IVUS.
IVUS, okay.
IVUS?
Yes.
Any preference, IVUS OCT?
Nowadays I'm shifting to OCT because you know we are using diamond back very often. Yeah. So I want to identify the calcification more clearly.
Do you use some
IVUS
nitro?
is not good for
Nitro. Do you use some nitro?
They
micro.
ask regarding we can use nitro.
Nitro? Yeah, please. If you want to use, yes.
Nitro. Nitro. કેટલું છે?
So perhaps at this stage you could explain to the audience what you're looking for with your intravascular imaging.
Okay.
Because I think many people here would just put another balloon and inflate, but I think we would like to learn from you what you're looking for with OCT here.
I want to remove this one. Okay.
So Dr. Saito, the panel asked you, what are you looking from the intravascular imaging? You're looking for calcium, the length lesion, what else are you looking?
I think there should be some calcium and
Calcium?
yes, not so much, but some calcium.
So if you see a lot of calcium, would you do atherectomy? Even though
yes,
even though
maybe
your Y,
in this case, I will take a rotablator.
you will rotablator. Okay. Even though your Y go into subintimal, you think it's okay, right?
Yes, no problem.
125 or 15?
No, at least 175.
175.
Starting from 175.
Start with 175. No problem for subintimal.
No,
Go in.
maybe only 1775 I take, and then after that I will place a stent. Otherwise, we cannot achieve the enough expansion of the stent.
Of course. Would you do 175 in this vessel?
I would do what the IVUS tells us to do, or the OCT tells us to. I should routinely, honestly, here, I think fluoroscopically doesn't seem like too much calcium. If it's not overly calcified, I would sort of be with Malcolm here and balloon nitro IVUS guided stent diameter. I think that's what we routinely do. You attack?
I think only if I cannot put the balloon down undilated vessel, then I do the rotor or laser. But if balloon dilatable, I will not consider that.
But I think your point is a good one. In the old days, we would say subintimal passage or intimal tear was a contraindication to approach, but nowadays it's clearly it's not exactly the same, but we have no problems doing atherectomy. And do you agree, Tak? And the panel, you guys agree? You're not put off by some subintimal passage and intimal dissection?
Absolutely, yeah. If you can't dilate, then yes, even if there is a little bit of a tear, we still rotablate.
I think if the IVUS shows that you're right next to the external elastic lamina with passage, maybe that would concern me somewhat about not just atherectomy, but about stent sizing and post-dilation.
Okay, starting from here.
So I think that's an advantage of having some intravascular imaging, I think, in this situation.
Let's see the IVUS now.
It's a currently normal vessel.
So let's see the IVUS image. The panel can see the IVUS, right?
Yes, we could.
Yes.
So you're pulling back from the mid RCA.
Still very far. Okay.
It's moving, right?
Yeah. Okay. Okay.
So we start again, okay.
Yeah, coming.
We could see the lesion coming up.
Here is
There's
a
some
lesion
dissection, some calcium, right?
Calcium, yes.
Some calcium at 6 o'clock.
Yes, I think it's wire is passing through the lumen.
Yeah, I was going to ask the same question, whether there was any evidence that this was subintimal or not. But
No subintimal space. This is a branch. So the wire is passing through the lumen from the beginning to the end. Okay?
Dr. Saito, are you surprised?
No. I'm not surprised. Okay?
But from the angio, looks like your wires are outside first and then go in. So from the IVUS, we need to review a little bit.
Yeah, and the vessel size is 1, 2, 3, 3, 5. Okay? So
the calcium is not much, right?
not so much.
There's only one nodule of calcium that you could see, so I don't think a rotablator would probably add much value in this case.
No, not useful. So I want to place 3 millimeters long stent. Is okay? How do you think? Okay, I will take angiography. Okay. Yeah. 3.0 or 3.5.
Which size? Length?
Length is at least 38.
338.
So there's a free 3.2 by alien by.
We don't have a quarter size.
You don't? No.
3.0, 38?
3.5? How do you think? 3.5. 3.5.
3.5, 38.
In Japan, you have the 48 millimeter stent.
Yes. Yes.
And India, you have 48 millimeter stent.
8 millimeter?
48.
Oh, yeah, we have it.
Even 45, 48 is fine. Just one.
48.
48 is good.
But
So Dr. Saito, even though your Y is in subintimal, would you change your strategy?
no,
Will not be a problem?
it's short, short segments. So I don't care.
You don't care? How long you care?
3.48.
Yes.
Yes.
Dr. Saito, I'm sure you use a lot of intravascular imaging and in this case ultrasound. And with your CTO practice, with your risk of perforations and pericardial effusion, how often have you picked up the effusion with the intravascular ultrasound?
First of all, I have to tell you that we are not so much afraid of perforation, wire perforation. If it is limited to the guide wire, it's not a dangerous situation. So yes, we do IVUS very often for CTO, but even if the wire is outside of the true lumen, like still remaining in subintimal space, we are not stop to insert the IVUS catheter into those regions. Because
actually, my question was, though, how often have you seen with the intravascular ultrasound evidence of an effusion? Just nothing to do with the ultrasound, but just the imaging aspect.
No, not so much.
Okay.
Malcolm, have you? It's a great thought. I don't.
Yeah. So the reason why I've asked is, fortunately, I can claim that I do very few of these very complex CTOs, so I don't have a very high rate of perforation. But I've seen some cases where we were doing intravascular ultrasound, and in retrospect, you could actually see the effusion beyond the vessel with the intravascular ultrasound. And in one particular case, we didn't recognize that the patient actually had a large effusion, but it was first recognized by, we could see it from the intravascular ultrasound.
Yeah. So this is a long stent, and Dr. Saito is trying to going in.
Or extension catheter? No, you don't have? No. Okay. So the big balloon. Yeah.
2.5 balloon.
You want to dilate more? Okay.
Which side? 3.0?
2.5, 3.
3.5. Okay.
15.
15.
Distal YT, just check it.
Yeah.
Okay.
Yeah, it's okay.
So what is the strategy now? Are we putting the anchoring balloon back in, or are we going to maybe predilate some more?
Predilate more.
Yeah, I think he want to predilate more.
That did
So
look
while
as
you
though there was quite a
predilate it-
severe lesion very proximally in there.
While you predilate it, Dr. Sato, you want to engage a guy more deeper
Yeah, but cannot do it.
or spasm?
Yeah.
It's small radial.
Oh, I see. Yeah, patient develop some spasm. There's a 7 French, all right?
Yeah.
Okay.
Okay. Go. 16.
16.
Okay, 16. Yeah, 2 5. 16.
16.
Okay.
One more. 16.
Okay. Okay, stent.
And just going to the panel, the US panel specifically, your same-day dismissal practice, does that include chronic total occlusions, or do you count that as a reason to observe the patient overnight?
Complete straightforward total occlusions would be okay for us. if there's any question, or if there is the procedure is too lengthy, or there's a question about the renal function of the patient, we would probably keep the patient in. It's very subjective. I don't think that there's a rule that you have to follow, especially when you do CTOs, and there's certain residual uncertainties.
Rajiv, are you concerned about delayed evidence of a perforation? Because I noticed that a number of your very complex patients, you do leave in overnight, and there's some of the few patients that are not same-day dismissal. So what are the concerns?
Yeah, I guess in the very straightforward, I mean, here IVUS, you're through all the way. I think this would be one case, if everything went well, I'd be comfortable going same day. But I agree, while we really moved across to same day dismissal, the CTOs we've typically kept overnight for the usual reasons, bilateral access, delayed perforation, as you're saying, maybe at some elevated other risks too. So it's one of the reasons we've kept people overnight. Maybe that will change over time. But my comfort level is still to, if in any doubt, the CTO would keep them overnight.
Okay. So the obvious question then would be, of the ones that are left overnight, have you seen a significant number of complications that you then are reassured that you made the right decision in keeping them in the hospital?
It's a great question. I don't know the numbers, and honestly, I suspect we maybe with hindsight have not needed to keep many of them overnight. It's just still that low frequency event of a serious complication is what concerns us. And we know from Aaron Grantham's registry data, and he'll, I hope, share some stuff with us, that it's not insignificant, the major adverse event rate. And I think for that reason, I do feel that maybe for now we should be monitoring patients a little closer. Tak, any comments on that?
I don't know. I think a very, very good question. The late perforation, I think we still discharge for even though same day, we still monitor the patient regularly for at least a 6 hour. So any perforation, if a 6 hour, I think we can see it, even though for CTO. So I don't know, it's really worth to monitor patient overlay or same day discharge. I don't know. Okay. For some patient, I do a lot of a bilateral radio, and bilateral radio, I had more reason to send the patient home same day.
It's coming. I mentioned earlier about 90% of our patients who are eligible, and it's most of them will be dismissed same day dismissal. But most of the ones that don't go home are the ones that are finished late in the day, because we still need to observe them, and so they can't be dismissed in the evening. And just because of the length of some of these procedures, particularly if we start them in the afternoon, I suspect it's just from a practical reason that they stay in hospital.
I think that's a really good point. I mean, there's this tendency to want to use procedural characteristics to keep people overnight, left main or bifurcation or rotablation, but really they don't play into the acute aspect. It's usually the social reasons, willingness, ability to be accompanied by someone else, or finishing late, at least in our practice.
100% agree. I think social reason play an important role nowadays in terms of anatomical thing. I think the technical, we advance a lot, and we're using a lot of imaging, radio, so very safe the same day discharge. Yeah. You can see the iris, right? Looks like the stents are opposed, very good.
We don't see the fusion. Malcolm, do you?
I don't think so.
Looks very good.
Looks very, very good, this stent. Opposed well, perfect. Okay. Are you happy, Dr. Saito?
Yes, of course. I will take the final shot, okay?
Okay, great.
Okay, ready?
Yeah.
Just this is out. Okay.
Any question from the panel?
Okay.
I can.
Yes,
looks very good. Looks very
excellent result.
Thank you.
Thank you.
Thank you. Thank you.
Yeah, congratulations.
Where?